Dean at Western Victoria Primary Health Network. I'm going to be facilitating the primary care stream today, and I'm joining you from Gadabanud country. You'll be pleased to know that you've just scored 10 points towards the lucky prize draw just by joining the session. And to score even more points, please make sure you stay with us for the duration of the session and fill out the evaluation at the end. And the prize will be drawn at the end of the day, so good luck with that. Thanks to Cubico for sponsoring this session, and remember to pop over to the Sponsors Lounge and browse through the individual pages. Cubico have plenty of resources there for you to check out. Welcome to our second session for the day, Business, MBS and Quality Improvement with Chris Smead from Cubico. We hope that this session will be interactive, so do pop some questions into the Q&A box on the right of your screen. And for any general comments, use the discussion forum. Also, please take note of the health pathway for this session, which may be on the screen at the moment or may be coming up, but it's also in the handouts section. So I'm now going to welcome Chris. Chris Smead is the co-founder and CEO of Brisbane-based software startup Cubico, an innovative platform dedicated to helping general practices gain insights into their business. For the last 7 years, Chris has seen firsthand the opportunities that can be realised through harnessing the power of practice data, having worked previously as Director of Finance and Business Development at Inala Primary Care. Chris is a surveyor for Australian General Practice Accreditation Limited, AGPAL, and a director of several organisations across the not-for-profit and commercial startup space. He's well known for his enthusiasm, high energy, commitment and proactive approach to making practice life healthier. So welcome, Chris, and over to you.
Amazing. Thank you so much. I'm so excited to be here on a Sunday morning. Thank you for taking time away from your families, away from your garden, maybe whatever you might be doing on a Sunday, to come and chat about a very, very sexy thing called data. To me, very, very sexy. What are we going to have a chat about today? Let's give you a quick overview. We're going to chat about recruitment and data for recruitment. We're going to have a chat about quality improvement. I don't think we could do a session with the PHN without talking about quality improvement. Then we're going to have a chat about the MBS and some chronic disease management. Going to apologise straight up. I am week 2 after having COVID, so a bit of a cough hanging around. So if I do have to mute, it is because that cough is there. I also love to chat. Any of you who know me know that I love to chat. So please type stuff into the discussion forum and the Q&A. And the amazing Matt is going to help collate that. And we'll have some time at the end to chat through it. So if we're all set, ready to rock and roll, I've asked Matt and the team, if my tech fails me, to jump in and interrupt. But apart from that, I get too excited. So I'm going to rock and roll. First off, who am I? Why am I talking to you on a Sunday morning about data? And I thought, if you're on Sunday morning and you're from home and you might be in your slippers, I'm going to share an embarrassing photo with you. That photo is me at week 3 in my general practice. I graduated as an accountant. Don't hold it against me. I thought, oh God, I don't want to be an accountant. I actually realized I didn't want to be an accountant, but I always had a really strong social justice streak. After you're busy, we've got a clinic called Inala Primary Care, and it's a not-for-profit general practice, so a bit different to other general practices. And I thought, yeah, I'll go and work there for a year. I'll give something back. We did mainly refugee health. So 3 in 5 of our consultations were a refugee health consultation. I actually had my last day in my clinic at the end of last year after 13 years. So definitely got hooked on general practice and hung around for a long time. Here's me and my practice team. Me and my amazing reception team. You can definitely see much more hair in that photo too. And a few more kilos or less kilos, depending on how many COVID croissants I've had over the last year or two. So I started working in general practice and realized we had amazing doctors, amazing nurses, an amazing reception team, but we actually didn't have access to business data. There was great clinical data tools out there. I know you guys use Penn. There was great tools out there doing all the clinical data, but there was nothing to actually help with the business of general practice. So look, I'm a nerd, never studied IT, as I said, studied accounting. So I started building dashboards. And I started building dashboards thinking, oh yeah, that's an amazing dashboard. Because I took our total billings and I took a report on total appointments and I divided them like perfect revenue per appointment. That's going to solve all our problems. But you know what? We were actually looking at all the wrong things. And it takes a lot to admit when you're wrong. And I realized we were wrong. We were looking at all the simple things, all the wrong things, not the things to make our business more sustainable. So you know what we did? We stopped. we stopped and we thought about it. And we realized the question we actually had to be asking, and one of the big things I hope you get out of today, is what don't you know? Or maybe better said, what didn't we know? What didn't we know about our business? What didn't we know about our practice that was going to be key to being sustainable? And you know what? By looking at all the wrong things, and I'm sure this will resonate with you in your clinic, I realized that we wasted a huge amount of time. Time is so precious in general practice, hey? And we wasted so much time looking at all the wrong things. We wasted a lot of money, not just a lot of money buying the wrong software, but wasting time, which equaled money. Everyone's wage had a cost. And by wasting that time, we were wasting money. And most importantly, and for me, most sadly, I think we wasted a lot of goodwill. You guys know from your doctors, from your allied health, from your nurses, from your reception team, every year you get that little pot of goodwill. You get that pot of goodwill. And that pot of goodwill means that they'll go on the journey with you. They'll go and do something with you that they want to do. So by doing that, we've been looking at the wrong things. So we've been wasting all that goodwill, the ability for those docs and allied health and nurses to be on the journey. So we stopped and we actually regrouped around a vision, around an aspiration. And ours was our team our data empowering our team to sustainably perform at their best for our patients every day. And you're like, Chris, this is a data talk. And someone said to me, Chris, when we saw that, we realized you were missing something in there. There's no mention of the word KPI. There's no measure of the word metric. There's no measure of the word benchmark. It's actually using our data to empower our team to look after our patients. And I think it's really important to rephrase the conversation around that to make sure we're using data. So what can you do in your clinic with your data? I'm going to tell you what we did in our clinic with our data. So we took data from our practice management system, which at the time was best practice. We took data from our accounting system, Xero. We took data from our HR system, which was Tanda, and we took data from the MBS. And look, it was me with spreadsheets doing it for the first year. And today I'm going to show you a lot of metrics. You can do them in Excel. You can do them writing your own SQL. So please don't think that to do what you're doing today, you have to have Cubico. We definitely make it a bit easier, but everything we look at today is something that you can calculate yourself. And to me, that's really important. I'm a practice manager. I want to make sure that all the practice managers and the practice owners and the amazing nurses and doctors and reception team members on this call today can get access to data to improve their clinic. And I think this is a great mantra to get your team behind. Using your practice data to easily find opportunities and solve problems. And that's what we're going to talk about today. Finding opportunities and solving problems. Now, we are doing a session with a PHN today, and I am a surveyor, so don't hold it against me. I love being a surveyor. I get to do that at some amazing clinics. So I thought the most important thing today was maybe start with a bit of a higher level framework. And we're going to start with something from the standards. Who's been through accreditation recently? Type a Y in the discussion forum. I think that's the right place to be putting it. I'm normally on Zoom, so it's normally type a Y in the chat. But Matt, nod your head if they should be chatting stuff in the discussion forum for us to see. If you chat a Y, who goes through accreditation and gets nervous and gets worried and makes a whole amount of work just before accreditation? That was me. I was a surveyor and I was having the panic before accreditation. So today, everything I show you, I want you to think about with how you can make life easier for yourself down the track during accreditation. These are some really important indicators. C3.1A and C3.1B. Our practice plans and sets goals aimed at improving our services. And C3.1B, our practice evaluates its progress towards achieving its goals. Two relatively new parts of the standards and two really important things that when I visit a clinic, sometimes they're an amazing clinic, so many amazing clinics to visit. And we get to these ones and they're like, oh, business goals, oh, haven't got that, not evaluating our progress towards this goal. So today, as we talk about everything to do with MBS and CDM, have a think. Have a think about how anything you decide to do today after this session could be tied back to planning, setting business goals and evaluating your progress towards achieving it. And I'm going to give you some tips along the way today to try and help make it easier to get there. One of the big questions I get is, Chris, why do we care about this business stuff? We're here just to look after patients. And it was actually this wording in the 5th edition of the standards that really tied it together for me. A business needs to operate successfully to create an environment where quality clinical care can be delivered. A business needs to operate successfully to create an environment where quality clinical care can be delivered. And that was a light bulb moment for me. If we're not a sustainable business, if we're not operating successfully, actually, how are we going to be there to deliver care? Need to have those things working together. I think it's a really delicate balancing act. Hey, you're going to have to balance the quality clinical care, that care for patients, with sometimes those business outcomes, the money, the MBS, the title of the session they gave me to talk about. But I think the most amazing clinics, the clinics that have really nailed it, are the ones who sort of work out how to sit on that seesaw of quality clinical care, and then can see through the forest, see through the trees for the forest, see what's going on. Sometimes you can get so bogged down in this bit here and this bit here and this bit here in general practice that it becomes quite tough to keep that overall vision from outside there. Now, when I was talking to your fabulous PHN team about 2 weeks ago about what we're going to talk about in this session, I actually hadn't planned to cover recruitment, but they said, Chris, please cover recruitment. And it was when I showed them this. This was a clinic that we worked with, and this was the number of doctor hours they had in their clinic for the next 6 months. And suddenly at month 7, there was no doctor hours in the clinic. There was no time, no doctors available to see patients. And the number one challenge that so many clinics tell me they're facing at the moment is recruitment and retention. Who's got that challenge at the moment? Who's facing a recruitment and retention challenge? Type yes in the chat down the bottom. Michelle's comment before, Y for that one. But if anyone else is having a recruitment and retention challenge, type a Y in the discussion forum. Just so I know there's someone awake and out there listening to me, even better. Otherwise I'm just yelling into the void. Oh, there we go. Michelle, capital Y-E-S. Love it, love it. Well, Michelle, I can't help magically make doctors appear. I wish I could. I'd be a very, 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 very wealthy man, I think, in this country. Oh, John, yes. But what I'm going to do is show you what a lot of other clinics are looking at when they're trying to talk to doctors about coming and working in their clinic. So it's a lot about putting your best foot forward, hey. It's a lot about putting your best foot forward. I'm lucky at Cubico to work with 800 clinics all over Australia. And this is what they've told me they've been putting in their recruitment and retention packets to show doctors why they should work in their clinic. The first one is being really transparent about how many FTEs you have in your clinic, but more importantly, your billings per FTE. So what is an average FTE billing per week in your clinic, and how many patients are they seeing? You know why? When you show this to a potential doctor, they suddenly get a quick grasp of what's going on and who they're going to be working with when they come to your clinic, but then also show it to them over time. And it was quite amazing. One of the clinics was telling me that they showed this graph and they showed that over Christmas, it dropped to nothing. And they were really worried about that. But when they showed the potential doctor, the doctor went, oh yeah, this must be real data because you're closed at Christmas. So of course there's no patients coming through during Christmas. The other really great thing to show them is when doctors are weighing up where they're going to work. And sometimes there could be some sort of, oh, if I work there, this is going to happen. And they come with a preconceived idea about what's going to be going on in the clinic. So a great way to show that and to attract doctors is to show what the average billings are per hour, how full their diaries are going to be, which is utilization per hour, and the patients per hour. So how many people they're seeing as a doctor in your clinic per hour. So some really innovative and exciting clinics have been putting these key metrics onto a great summary page. And when they're recruiting and attracting talent, they're providing this information straight up. And it gives them so much confidence to come and chat to you more in your clinic. Along with that, particularly if you're a new clinic or you're in an area that might be seen to be in decline population-wise, is showing new patients. So how many new patients are joining your clinic and how the cohort of the clinic is growing. Now you can do this all in Excel and put it together a fantastic little way there and have it ready to show doctors when they come. We also worked with a great clinic up in North Queensland. Relatively small town, had 2 doctors' surgeries. Doctor was moving to the town. and was choosing between two clinics. Fantastic problem to have in a way. And same service fee, similar diary, similar structure. And they showed the potential doctor this data. And that doctor chose this clinic in a heartbeat. And that was showing this potential doctor a view of all their recalls and how they were being actioned, and a view of all their investigations that had been contacted but not given, and that the practice was chasing up. And if you're trying to attract someone to your clinic and you can show them how good your workflows are, and by showing that potential doctor these workflows, they were able to attract them to their clinic without having to change the service fee, without having to lower it, because the doctor knew if they worked there, they'd get a better night's sleep because they know what was going on. The other big part of that is also just showing how long people stay in your clinic. When you've been talking to doctors and trying to attract them, have you said, oh, look, the average tenure of someone to stay in our clinic is about 6 years. If doctors are staying in your clinic for 6 years, it's a great way to attract other doctors because they're aware that things must be pretty good there. So that's a bit on recruitment. I hope that's been useful. As I said, wasn't the original plan for this session. We're actually going to talk about all this exciting stuff now that we're going to have a chat about, which is MBS data and tracking what's going on in your clinic. Now, I love thinking about it in sort of a double whammy: tracking and lifting performance. Tracking and lifting performance. And remember before we spoke about the standards, and the standards said you have to have goals and you have to evaluate your progress towards those goals. Sometimes that can sound a bit, how do we get our head around that? So I prefer to think about it tracking and lifting performance. And for me, I don't know whether this is coming through well in the video, it's climbing the stairs. It's getting better and better all the time. We do something, we get better, we have a little break. We do something, we get better, have a little break. But you know the cool thing about thinking about tracking and lifting performance? It all starts with understanding your performance. And that so happens just to be those stairs on the side, making a fabulous line graph there to see how we're going. So for the next 6 or 7 minutes, what we're going to have a look at is tracking and lifting performance, but mainly around tracking your chronic disease management. When I spoke to the amazing PHN team there, they said, Chris, it's amazing to have all this data, but today in this session, can you focus in on CDM? So we're going to focus in on CDM today. I've got some great blogs on my website if you want to look at how to track other things, broken down to things for your receptionist team to track, things for your nursing team to track, things for your doctor's team to track as well. First off though, as I said, it's the business of general practice today. The session's called Business Session. I love starting with a Billings target. If you look at this clinic, you can see what they're billing each month, which is great. And that's the light blue line there. But what they've done is they've also set a goal or a target. Now, sadly, they're not hitting this target just yet, but they knew that target was the point that they would be breaking even, and not just breaking even, but making the profit to be a really sustainable business. And historically, they just got that data once a year from their accountant. And they didn't know how they were going until 5 months past the end of the financial year. But by making an Excel spreadsheet or using Cubico or whatever tool it is you use, and having your billings and your target billings, but then also a year-on-year comparison, you could do it nearly every day to see how you're going. And I don't know about you, but sometimes in my clinic, I had those really sleepless nights when I was just trying to make sure, are we okay as a clinic? Are we okay as a not-for-profit? And by having this and knowing where I was at, it gave me a lot of context to what was going on. The reason I start here is the next way that I love to then look at it is tracking your CDM billings year on year, month by month and year on year. Because we know that there's those natural cycles in general practice. We know flu season in April, and we know that December is always a weird time. But tracking your CDM billings each month quickly lets you know where you're at and what's been happening year on year. To break it down further, I love looking at it as a percentage of total billings. CDM as a percentage of total billings is really powerful because it gives you a barometer to what of that total billings is being done to look after your chronic disease management patients. And even better is to look at it doctor by doctor by amount of CDM and percentage. By amount of CDM and by percentage. And if you're building an Excel spreadsheet to track this, I wanted to show you this. Up here, we've got each doctor in their clinic and what their CDM billings were dollars-wise. The red dot is what they billed for the same time last year. Down below here, though, we've done it as percentage of total billings. And you can see up here, this doctor was quite low. She was quite low with her CDM billings. But if you look at the percentage of total billings, it's actually quite high. I don't know about you, but in my clinic, we had a lot of doctors that might do 2 days a week or 1 day a week. But then we had a few doctors who did 5 days a week. So looking at the raw dollars, it looked quite high. But when you looked at it as a percentage, you suddenly knew what it was of their total work. So a really key one to look at there. Now, pairing that CDM, and we know what CDM's going on, the other big driver or limiter on your CDM is going to be your doctor and nurse availability. Your doctor and nurse availability. And is anyone else like me, and hopefully Michelle's still there in the chat out there, who looks at your diaries in best practice or medical director every day, and there's all the columns, all the gray and all the colors and all the filling and everything like that, and you think, oh yeah, our diaries were pretty full, I think, but I don't know what this was and I don't know what happens there. I love looking like time like this, and you can find a way to represent it in your clinic. I use left to right, 100%, so all time open to see patients. Purple is the time that our doctors or nurses were with patients. Green is when they were doing admin or non-patient facing activities. And blue was their available or unbooked time. And the reason I show you this when we're talking about CDM is to look at our nursing team. And in this clinic, you can see in this sample data set, these nurses have really, really full diaries. Really, really full diaries. So if we want to encourage to increase our CDM, we need to have our nurses, hopefully if it's nurse-led CDM, I know it might be doctor-led CDM, on board. Where's that time going to come from? Maybe it's moving some of this admin or non-patient facing time onto our amazing reception team, or looking at outsourcing or things like that that can open up more nurse time to do CDM. And then I love to break it down even further and look at each one of our nurses and see how full their diary was, but how much unbooked time they had left available. Because once again, there's no point doing more work around lifting your CDM programs in your clinic if you don't have any time or resourcing available to do it. You're just going to be that person making a lot of noise and giving everyone a problem, but no solution. So that's your nursing and making sure there's available capacity. Another great way to get your head around things in your clinic is on the y-axis, plot your appointments per hour. So what's your throughput of patients? And on your x-axis, plot your billings per hour. And then plot where each one of your doctors sits. And who'll be the doctors down here in the bottom right corner? So they're not seeing not seeing very many people, but they're billing quite well per hour. They'll be your docs that are doing all their own CDM, so not using your team. And what we found with about 50 clinics that we tried this with an experiment, they paired them with the nurse for the day or two. And the nurse showed them how they could help them do their CDM. And suddenly those doctors went to seeing more people per hour, but their billings also went up per hour. So they became real superstars in their clinic, but they also became a lot more happy and a lot more wedded to the clinic because they knew they were getting the support they needed in that clinic. Now, when we're talking about CDM, I bet you some of your doctors, and love it in the chat if someone had this conversation, said, oh, if I do more CDM, I'm going to get a Medicare audit. Matt, I'm sure if you've ever heard people say that if I do any more CDM, there's going to be a Medicare audit coming my way. What we do, and it's publicly available data, so you can do it too. We scrape the Medicare website every month, and we look at the ratios of those standard consults to CDM to health assessments. And I'm not saying if you're below a certain threshold, you're going to get an audit or you're not going to get an audit. But I love it when I can go and have a conversation with one of our doctors and say, look, our clinic does about 10% chronic disease management, and the average for the state for Medicare is about 9%. So we're pretty, in keeping. But look at this doctor here. They're doing 45% of their billings as CDM. Is there any point investing your time, energy, and resources to help that doctor do more CDM? Probably not, hey. But look at this doctor down here that's doing about 3%. Is that where you could do some really targeted quality improvement to help them along? Totally. Is that where you can show them that doctor says, oh, look, I don't do any CDM because I'll get an audit. And you can say, well, look, actually, the state average or the practice average is 10% and you're sitting at 3%. So, I can't tell you definitively yes or no, but you are sitting there and you're sitting a bit different to everyone else. So hopefully that's something useful to strike up that conversation. Finally, it comes down to a bit of a dollars thing. And one of the most popular metrics in Cubico that I talk to clinics is actually looking at their database. And if you're using another clinical information system like Penn or Polar or one of those things, there's a lot of different ways you can be getting this data. Looking at your database and where you're seeing where you have opportunity. And if I said to you today, you are that clinic we had up there before, and the nurse was sitting at 99% full in their diary, but you have about $225,000 of opportunity to provide CDM care in your diary, would that make it an attractive offer to look at hiring another nurse? I think it would. If you could build $200,000 in CDM, but you need a nurse to do it, that's a really attractive offer. And we've also seen a lot of clinics start offering a different distribution on the CDM work as well. So a lot of their nurse-led work is now being on the doctor distribution done at a separate way. So, hey, I've got about 10, 15 minutes left. So I wanted to show you some quick ways to improve your CDM. Some great ways to use data. I'm going to be showing you screenshots from Cubico, but I want to be really transparent that a lot of this data can be found if you write your own SQL scripts or using some of the other clinical information systems. We've got best practice, we've got MedD, we've got medical, all these different systems. I'm sure you can jump online and find queries, but I'm going to show you how we do it because that's what I live and breathe every way. So we've been tracking out how we're going. Now it's time to talk about lifting performance. And the big one that I'm seeing, and there's an amazing opportunity to engage with patients, is who can remember about 12 months ago, I'm sure you can all remember, the amount of work we did finding patients in phase 1B and 2A for COVID vaccination. We did a huge amount of work finding those patients. Huge. We did some work with best practice on it. And we actually found that we found a lot of those patients. And there's queries out there from when this was all happening to find those patients. Our clinical advisory group, there's about a 99% correlation between those patients and eligibility for a care plan. And our doctors have been loving using that to engage with patients around CDM. You know why? It's not finding someone who had a diagnosis of asthma once 3 years ago, and suddenly we're bothering the doctor saying you should put the patient on this care plan. It's actually a much smaller list, but a much higher quality, and I'm using the word in inverted commas list there, of patients that would benefit from CDM. So start with that, look in the diary and find eligible patients that you can engage around chronic disease management. How do you do that? I'm going to show you how I do it for 75 plus health assessments. We look at the diary and we said, look, in this clinic, there's 661 patients eligible for a 75 plus health assessment. If you did them all and booked a 701, so not even a 703 or a 705, which you probably would bill, there's $40,000 worth of work. And we used to just have that at the top of the page. And people would be like, Chris, you're terrible at making me feel bad by telling me I've got $40,000 worth of overdue 75 health assessments. So what we did is we then married it to the diaries. And if you're doing this yourself, marry it to your diary. Don't just have lists and lists of patients eligible things. Tie those lists to when the patient is coming in next. So today at 10:40, this patient's coming in to see this doctor and they've never had a 75 plus health assessment. And you might say, oh, Chris, they're new to the clinic. In the last 2 years, they've had 28 appointments. That patient is not new to the clinic. Is that not a fantastic way to get your team around providing care to the patients who will use it and are part of your clinic family the most? We're taking it a step further, and a lot of clinics are taking it a step further, and now look at each appointment for each one of the doctors each day and work out what those patients might be eligible for. Look at each appointment for the day and see who they're seeing and work out what they might be eligible for. And we've got about 200 clinics of the 800 we support that use what we call our doctor direction cheat sheet. And hey, I'm trying to be a nice guy. And so I've got a QR code here if it comes up that you can click or go to that website and download what we call our doctor direction cheat sheet. And I'm going to tell you how we use it in our clinic. And if you take out one workflow today, hopefully that's one of the workflows. And look, this is a really old school solution. And I know I run a tech company and should have a beautiful tech solution to this, but sometimes paper just works really well, hey? So we had little cards, and pre-COVID they were laminated and they were colored orange. And we put these lists of opportunities on each doctor's keyboard each morning. I put them on orange paper because I had a fear that a patient could work out with a list of patients and a script and a referral. We had an orange paper never leaves the clinic policy in our clinic. So the doctor knew that was their list for the day. And when they were sending the patient back to referral, they'd use our little cards and say, book in Mary for her over 75 health assessment and her home medication review. And our eagle-eyed reception team knew that whenever that orange piece of paper came to the front desk, they had to book something in. And I know, as I said, I run a tech company, and I know it should be a beautiful tech solution. But you know what? Sometimes paper just works well. So there's a great link to go and download that link there as well. Speaking of our nurses, our fabulous nurses, who on the call today thinks they're taking advantage of all the 10997 opportunities from their chronic disease management patients seeing their nurses? I know for us in our clinic, you can put the hand up and say the last 2 years, we were so too busy with COVID vaccine, our 10997s totally slipped. So what we did, and what you can do with a query, is actually find all patients that because of their MBS billing are eligible for a 10997, and then look when they have seen the nurse. And before someone gets uppity in chat, no, you can't go and bill every one of these. You need to do a chart audit, and you need to do a chart audit to make sure what was discussed in that appointment with the nurse was actually making the appointment eligible for a 10997. But if it was, you can go back and bill it. And we've had many clinics find a lot of money in work they've done, but had just been forgetting to bill the 10997. So once you've done that, and you've gone back and chased up the past 10997s, a great way, once again, is you look at your diaries, look who's coming in today, and see who's eligible for our 10997s. And our nurse now has this open on their desktop and reads it and says, oh, look, Mary's coming in half an hour. She's eligible for a 10997, and I haven't caught up with her for 2 months. So they're using this to proactively manage their data set, but then that's also increasing their billings. And it's also giving better patient care. Win, win, win. Who here put the rollout of their COVID and flu vaccines onto their quality improvement register? It was the biggest quality improvement I think many of us have done in a long time. And it should be on your quality improvement because it was a change in the way your business operated to improve the quality and availability of services. But one of the big things we found is the rollout of COVID vaccines is a lot of clinics, because things were moving so fast, forgot to bill a lot of COVID appointments. So make sure you do an audit of your database to find any of those missed COVID appointments, but also any missed 93666s. A lot of them were missed because, as you know, the things were changing so quickly as well. Speaking of missed, it will amaze you the number of appointments that missed getting billed. And we're not just talking about ones that sit in a different color on the diary. The number of appointments that missed getting billed is enormous. We had one clinic that found $60,000 in the last year alone. The reason being is in a lot of our practice management systems, you don't have to have an appointment to see a patient. You can open up their chart directly and see a patient. And particularly with telehealth, how many times have phone calls been made, appointments conducted, that never make the appointment book? So if you're looking for a little end of financial year boost to your clinic, if you want to make sure your doctors are getting paid for all the work they do, start with your missed billings. Great little sugar hit there for your clinic. And then sometimes too, it's pretty important to triggering some patient payments. Remember also patients will have the safety net as well. So you want to make sure you're putting all your billings through. Huge bit of work going on at the moment around moving to mixed billing. Huge amount of clinics moving from bulk to mixed billing. And we've been helping a lot of clinics with that. And the biggest area I'd say to start with analysis, and if you're going to do this in Excel, start with your Excel analysis, is looking at if you're talking to your doctors about moving from bulk to mixed billing, look at the biggest question we get is moving from what will I lose in my incentive payments that I'll make up for in mixed billing? And that's that average gap. It's actually quite easy to do that when you start cranking through your data. And when you show your doctors the evidence, it makes it a lot easier. Second last one, and then we're going to have time for some Q&A, which I think is just bang on the extra schedule, is the diary mix. And I'm hoping there's some practice managers on today. And if this is a sort of little takeaway for you to take back to the practice tomorrow, I'd be really excited. You can do an exercise where you look at your appointment type. So here we're looking at our standard, long, and recall appointments, and look at what is being billed. So if you look at your standard appointments, you'd probably say, yeah, we expect them mostly to be level Bs, yeah, your 23s. And your long appointments, yeah, probably going to be your Cs. What are you expecting your recalls to be billed at? I had a lot of people say, oh, we expect our recalls to be As and Bs. And then they do this and they find out that a majority of their recalls are actually being billed as Cs, but are being put into the diary at the length of a standard appointment. Is that doctor going to be running late for the day if they have 3 recall appointments in the morning? Yes. Are they going to be stressed? Yes. Could you make their life a bit better by just a little tweak to their diary? Totally. And have a happier workforce. So to bring it all together, I want to give you an example of a great quality improvement cycle that we can do. Jump one slide. So here's an example of our 699. So our healthy heart checks. If you took your patients eligible for them and what it could mean for their potential billings, is that a great business goal? Is that something to work towards? Is that something that's going to help your business sustainability? Yes. And then if you overlay it with a list of when people are coming in today to use as a prompt, and we use those worksheets I provided before, is that a great way to make it happen in your clinic? Yes. And I think the best bit of it all, are more patients going to get a healthy heart check? Are we going to be looking after more hearts? Yes. That's pretty awesome. Hey, win, 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 win. Now remember, as you go, make sure you evaluate. Remember there we're looking at our CDM and our year on year. How has it gone? Don't wait until the end of the year to look back and see what the total CDM percentage is. Track it each week or each month to see how you've gone. And one of the best things I love to tell clinics is use wait time as your canary in the coal mine. If you've got Dr. Jane, and Dr. Jane has always had a wait time at 5 minutes. And you look back the last 12 months, the wait time was 5 minutes. Suddenly you make some of these changes and Dr. Jane's wait time goes to 10 minutes. Or maybe you don't make any changes and Dr. Jane's wait time goes to 15 minutes. I've always said that wait time for me is my canary in the coal mine. If someone's wait time suddenly, for no real reason, or we have made a change and their wait time does change, to me, that's always a flag that, oh, something's going on there. I need to go and have a look. And maybe need to buy Dr. Jane a coffee and just check in and say, how are you going? Have we changed something? Do you need something? To make sure that our doctors are getting what they need from our practice. Now, I got told to leave 10 minutes for questions, and we are at 10 minutes left with questions. So Matt, hopefully that was useful.
Yeah, fantastic. Thanks very much, Chris. Really appreciate that. So we do have a couple of questions. I don't know whether you can see the questions. I'll read them out so everyone can hear them.
I'm just flicking over to it now. Sorry, guys. I get too excited.
No, that's fine. So I'll read the questions out so that everyone can hear them. So that you don't have to go and read that out. And I'm doing some work in this session. So
yes,
all good.
And I'm going to have a sip of water because my poor COVID chest is still on the mend.
Fair enough. Yes. Do some self-care. So the first question is, with 721, 723, can you bill with 10997 when the patient has had a care plan 2 years ago as ongoing nurse education during consultation? Can 10997 also be billed by itself without other attendance item numbers such as item 23, 36, 44?
Wow. Okay, that's quite a complex question. I'm going to say, without knowing all the circumstances and everything like that, and there's a lot to break down in that question, I'd reach out to Ask MBS and double check with that, or your PHN to ask their schedule. As I haven't worked in general practice for 9 months now, so I'm a little bit rusty, but I'm very lucky that I do have 5 practice managers, and I put this picture up because there's 5 practice managers who work at Cubico. So that'd always be the people I'd reach out to. I just don't want to give you the wrong answer and you to come after me if you've got a Medicare audit. For me, as a software company, offering MBS advice is a little bit risky. So, yes, sorry, I don't want to sound like I'm dodging the question, but I just can't provide.
No worries at all, Chris. And I know that at the PHN we have wonderful practice facilitators. So we'll take this question, make sure that we get the right, accurate answer, and get word out to the team.
Yeah.
So that's easy.
Yeah, and I'm pretty sure that the 10997 is fine to be built, because you might be coming in for a 10997 and a 23 or 10997 and something else those days. So that's the nurse care. But the bundling and things like that, I've heard so many different answers over the last 2 years. I just would hate to put whoever that is asking that question in the wrong seat. And look, then they'd hunt me down and want me to pay their Medicare order bill. So, but I think the thing I always say to people, and it's my philosophy, and look, it's just my philosophy, is that if a doctor does the work or a nurse does the work and it's permitted by the schedule and it's documented in the notes correctly, we need to make sure they're being paid for it.
Yeah.
It's actually a really important thing. Sometimes I think we all get a bit too worried about, should we bill this then and should we do this then? But actually, what other business, would you go to a restaurant and eat 2 courses and they get a bit worried, the bill might be too much, I'm not going to charge you that?
Or it was served on the wrong plate, so I'm not paying.
Yeah, exactly. So yeah, I love Ask MBS because you get it back in writing and you can save it in a file somewhere. Great tip I had from someone. It was a case that happened about a year and a half ago. They'd done Ask MBS, but then lost all their emails and they had an audit. So make sure that email gets backed up. And even better, when you get that response, we actually add them as a standing item on our practice team meeting agenda. Because what that does is it shares that response, not just with the doctor or the nurse that asked the question, but with the whole team. I don't know about you guys, but how many times have you walked into your tea room and someone's having quite a heated conversation about MBS and eligibility and billing this and doing this then? And you've got one person with one opinion and one with another opinion, and you know you have the evidence to make that conversation correct from the start. That can be a really awesome place to start. Sorry, Mark, got a bit waylaid there, but just
no worries. But yeah, that's a nice idea about making sure that that the knowledge that comes it becomes corporate knowledge in the practice across everybody. So that's great.
Yeah.
But there's one other question here. The same person. Good on them. 2 questions. Good on you. I also checked on HPOS as well, that when I tried to do 721, 723 with diabetes cycle of care on the same day, it showed. Oh, hang on, that just jumped. It showed 721, 723 and diabetes cycle of care could not be billed at the same visit. Is that true? Does it mean patient has to come back again for diabetes cycle of care in the next visit? Again, you may have some advice here, but fine if you don't.
Yeah. So I'm being very put on the spot. So big caveat. My recollection was that it couldn't be billed on the same day. But I, once again, would reach out to the fabulous PHN or your Ask MBS, or if you've got Cubico, give us a buzz. But I just get really nervous offering general advice like that.
Fair enough.
And sorry about that.
Yeah, and here's an easy one. We use ZMed for our clinical software. Is Cubico and ZMed going to work together?
One day. So at the moment, we work with Best Practice. Genie is currently in beta testing. Following that, medical director. So medical director is probably about 8 to 10 weeks away. Fingers crossed, all going well. So jump on our website if you're a medical director and want to be early access to that. And then ZMed will happen after that one. So we're just a small company up here in Brizzy. So, we have to do things in order.
Yeah, wonderful. So look, that's all of the questions that we've got there on the screen. But I suppose one thing I'll do
my homework better next time. Make sure I've got my MBS detailed knowledge ready to go.
Well, you can't anticipate every question that's going to be asked, and that's the beauty of live sessions, isn't it? But one little question that I'll ask you: what in your sort of dream world, if you could get anything to change policy-wise, I'm talking about federal health policy, MBS, policy, legislatively, culturally, in order for life to become easier for practices from a data point of view, what would you change? You're king of the world here.
Yeah, king of the world. So I'm a nerd, so I love stuff. Sometimes I'm like, why do we use the same item number for the two of the different? Why are we using a same item? Why are we recycling same item numbers for some things when we have a million numbers to choose from? But also, why are we making the descriptors in those item numbers more complex than what descriptors of item numbers should be able to be understood in plain English. And it shouldn't feel like a gotcha test.
Yeah.
And I think that is something that we are all working our guts out in general practice. I don't need a gotcha test to realize that I didn't read Appendix Note 1 on Type 3. So I think that would be a thing. I am so excited for the 10-year primary healthcare reform strategy. I think the fact that we're going to start looking at our patients in our cohort and how we can look after our patients is amazing. And one of the biggest things I've done as a software company and with our team is that we now roll out individual Cubico to individual doctors' phones so they can look after their patient cohort. And I kind of love it when we get back to saying, Dr. Jane, here are your patients. And they're the people that Dr. Jane cares about and knows about and has as her patient community. And at the moment, we don't get funded to look after Dr. Jane's patients as Dr. Jane's community. We've got 2 fee-for-servicing. So anything that brings back that relationship to being like this, I am just so excited about and general practice fanboying about.
Yeah. So that what you've just talked about probably sort of feeds into the final question that we've got here from Rowena Clift, our CEO. And she asks, what consideration have you given to voluntary patient registration and how that might work? Yeah. And that's a bit of a future, gazing question for us to finish on.
Look, I am so excited for that. I have a team of people working on how our software can be there to help you through it. That's the best thing I can do as a software company is provide tools that let you do your job of looking after people easier, but also help you get ready for that. And there's a reason I spent a fair bit of time talking about 10997s today and engaging your nurses with your patients. Because I can bet you $50 that the big corporates and the bigger groups are going to be getting ready for it. And when enrollment, and I'm using that word or whatever it's going to be called and however we phrase it, many more political minds that are much smarter than me will have different opinions. But I can guarantee you when this starts, they're going to be getting as many patients to enroll in their clinics as possible. What's the best way to make sure that little old Jean, who's been coming to your clinic for 10 years, doesn't get an SMS or an email or a phone call or something and get them to enroll in a different clinic? It's to make sure they've had all those incidents of care, where it's a nurse piece of care or allied health or everything has happened through your clinic. Because you know what that patient's going to say? I get looked after at XXX clinic, hey. And it's going to be just built into the feeling, because I know some clinics we work with are also saying, they're giving people the card saying, my nurse is, my doctor is.
Mm-hmm. Yeah.
And that relationship is built before we even start putting labels on it. But at the end of the day, if we don't end up putting labels on it, that's still a better patient outcome. And that's why we're all in this game.
Yeah. Great. Thank you, Chris. That's wonderful. So we have come to the end of the session. Thanks, Chris. That was a great session. I learned a hell of a lot, and I hope that the other delegates did as well. So now, people, we're going to have a 20-minute break. So please take some time to stretch your legs, grab a drink and something to eat. It's a very short little lunch. Also, if you get some time to visit the sponsors and the Westvic PHN resources, earn some more points so that you can get that $200 prize at the end of the day. Please make sure that you're back and ready for the start of the business session with Kim Poyner and Rivka Hagen at 12:10 sharp. So that's sort of 20 minutes away.
Don't get better presenters than those two. So, I might even hang around for that one. They're amazing presenters.
Oh, good. Please do. Yeah, that's wonderful. So, yeah, thanks very much, Chris. We're finishing the session. Please click the exit button, everybody, and pop back in at 12:10, and we'll see you then. All the best. Thanks, Chris.